The British Orthopaedic Association, which was founded in 1918 after World War I, represents all trauma and orthopaedic surgeons. What that means is if you go into a hospital with a broken bone, we are the surgeons that will look after you and hopefully fix you. If you come to hospital with an osteoarthritic hip or knee or a painful shoulder or an elbow, again we are the surgeons that are trained to deliver the care to actually make you better.
We have three core strategies on which we focus all our work, and those are excellence in professional practice, excellence in training and education, and excellence in research.
At the moment, we're a country where we have an ageing population, and musculoskeletal disease is becoming an ever-increasing problem. And we've got to respond to that within the constraints, if you like, of financial austerity which the country finds it in. Although there's been a 1.1% real terms growth in the NHS budget, with the ageing population, we've got a real problem. We've got to find ways of making sure we can continue to deliver excellent timely care for less. There are three strands to this. The first is beyond compliance. That is a methodology where we're working with industry and others to make sure that when new implants are introduced, that the patients are getting high quality care, and that if there are any problems with these implants, that they fail early, that we pick those up very quickly. That will benefit patients. The other thing that we've done is in terms of care pathways, commission care pathways, and we have now been working with the BOA, with GPs and commissioners, working out care pathways for 6 disorders that accounts for 40% of referrals. And that gives GPs information on who to refer, when to refer, and how they should manage these complex and simple problems. That should make sure that the right patient goes to the right specialist at the right time for the right treatment. The third strand is a national pilot called Getting It Right First Time, which has now got government support, and they've given us £250,000 to introduce this over the next 12 months. What we're doing is we're going to see every single individual trust in England with a unique data set to help them improve the care we deliver to patients, and again make sure the right patient gets the right specialist with the right problem for the best outcome. That will probably mean that we're going to have to reorganise in networks how we deliver care, but as the BOA we realise going forward that if we are going to maintain timely, effective care, we've got to change, and we've become part of the solution. It's no longer being reactive, we are proactive, and we're showing government ways in which we can improve care with the BOA behind us and supporting us.
EOS is a medical imaging system dedicated to the imaging of osteoarticular pathologies, hip, knee, back, and the orthopedic surgeries associated. The system combines a Nobel Prize-winning low-dose X-ray detector and proprietary software technology that produces 3D modelling of the patient's bones from just 2 radiographs. EOS enables whole-body frontal and lateral images to be acquired simultaneously in a natural standing or seated position, with very low radiation dose and no compromise on image quality. In less than 20 seconds, 2 full-body digital radiographs are taken. From those 2 images, a 3D bone envelope can then be obtained, together with precise 3D anatomical information, opening the way to advanced therapeutic planning and control of orthopedic treatments.
One of the most important things that I was able to detect when I first looked at the EOS solution was that it was complementary to the tools that we already have for imaging the body. And most importantly, when we're looking at the skeleton, it's important to try to image the patient standing up. That's possible with conventional X-ray radiography, whether it's computed or digitized, but normally with CT and MRI, it's not possible. So EOS provided a way of using X-ray technology to acquire an image of the whole standing skeleton and display it as a frontal and lateral scan, which was a very important tool in trying to understand the causes of pain in the skeleton which normally occur when we stand. The EOS system uses some very important technological advances which aren't immediately evident when you look at the machine, but inside there is a very advanced form of detector which, as we know, came from the Sharpak detector technology developed for CERN, One of those benefits of it is that it is very much more sensitive to the irradiation coming into it than conventional detectors, which allows us to use a lower dose. From the point of view of our referring clinicians, be it surgeons, general practitioners, or even the specialists allied to medicine like physiotherapists, the importance of the EOS system is that for the first time they will have a fully documented objective measurement of the spinal and pelvic parameters, of limb lengths, of orientation of the limbs, which are relevant to conditions relating to pain in the spine or painful joints. When the patient is confronted with the EOS scanner, they see a very friendly environment. They don't have to strip off necessarily. They can stand in their ordinary clothes in what is like a small telephone booth. So the presentation to the patient is actually quite non-clinical. They're asked to stand still only for a minimum amount of time. The impact of EOS in my clinical practice was immediate and is continuing to grow. I think one of the things that people need to appreciate is when you are taking on board a piece of revolutionary equipment, the impact it's going to have on your practice. And from my prospect, it's not just the sighting the equipment, it's also how to use it, learning what to use with the data that it gives out, and also learning to work with a group of clinicians who will take action on that data.
Reducing exposure dose to patient is one of the major challenge for our profession. Our modality in terms of diagnosis has a big yield, but before of its success, we're increasing the number of examination. And so the problem is that the burden of radiation is increasing, and therefore, of course, there may be side effects, and we are much more aware of this. So for us, one of the major issues is to do better with less radiation. Especially in Europe now, we have regulatory obligation, which is a very simple principle, which says that you should use the minimal dose which is necessary to achieve one special diagnosis. This is the ALARA concept, which means as low as reasonably achievable. What we have achieved recently and we have published show that we can diminish the dose, achieving the microdose, by a factor of 6. The optimization of microdose was set up especially for scoliosis in the adolescent population, so it's really high. And the population is at risk, especially in adolescents, because you have the growth spur, and so the curvature can double or triple. So you have to have a very good monitoring at this period. And of course, you can do this only by doing repeated radiographs to measure the curvature and to set up the appropriate treatment. Therefore, you need to have repeated X-ray every 4 or 6 months. But really, in the adolescents, it will be every 4 months, frontal and lateral view. So you can see the burden. So moving for repeated monitoring with a very precise method, and since we have very good angle measures and low dose, would allow us to have better follow-up.
The technique and the technology has been really spectacular also from just the standpoint of giving us beautifully clear images. So the image quality is superior to what I had with digital radiography. And this capacity to make a three-dimensional reconstruction from those two X-rays obtained simultaneously and in this registered perpendicular frame.
The EOS system gave us a lot of new perspectives on the 3D deformity of scoliosis, especially in the children. It gives us the possibility of doing a 3D reconstruction of the whole spine in a standing position using only 2 views, the PA and the lateral. We can get a 3D reconstruction of the whole spine with the intermediate structures, the disc space, and the vertebral bodies.
So when we put those two images together, we find that the EOS reconstruction is really very, very accurate. Within a millimeter of position and within a degree or two of rotation.
I am using this technology since 2006, and I have the experience about 3,000 of patients. We use EOS for diagnosis, of course, to understand what is the problem of the patient, and for planning of our surgeries. But I think what is very important is the communication with the patient. For the first time, the patient is able to see the whole skeleton. So the patient understands much easier what we say. And I use those images to discuss with the patient, to demonstrate what is the problem, and also to explain the different stages of what we do. And as a hip, knee, and spine surgeon, sometimes we are to decide if we begin using spine surgery at first, or hip or knee surgeries at first. So I think it is really a key point. This man was operated, he had the previous posterior fusion, and you see that he has imbalance. Is it due to the spine, to the hip flexum, or to the knee flexum? You have to discuss with him to convince him to do the correction at the spine level. With those images, it is very easy to explain him the global situation. It is also very easy to explain him the final result. You see, we did only the spinal correction, a wedge osteotomy, and you see that this spinal correction induced a correction of the lower limbs, doing nothing on the lower limbs. So it's easy to explain previously, but also to explain the result postoperatively. For spine surgery, the analysis of the sagittal and frontal balance is a key point for scoliosis, for osteotomies in the cases of correction of imbalance. In degenerative pathologies of hip and knee, it is also very important to have the full image of the patient for the planning of and the adjustment of the prosthesis. My practice has really changed with EOS because initially we used small X-ray and we had difficulties to have simultaneously the AP and the lateral view of the patient. For example, for the spine, it is absolutely mandatory to have those two views to decide the correction and to understand also the failures. For the hip, most of the surgeons only use the AP view. And it has been a fight for me to convince my colleague of the interest of the lateral view. Now, all of the surgeons around me are convinced of the interest of this lateral view. And what could bring us this concept was the EOS.
The BOA has developed I think a very important strategy that we realise that in terms of research that we're not doing enough as an orthopaedic family. If you look at what we do, we're 33% of the workforce and 25% of all surgical interventions in the secondary care sector are trauma and orthopaedics. So we are a very big player in the game, and the budget for musculoskeletal disease out of the whole healthcare budget is about £11 billion. So we have to be innovative and show that we can do this research if we are going to maintain timely care for patients. So we have a strategy that we're going to focus on translational research, and what that means is taking an idea in the laboratory, testing it in the laboratory, and then taking it to the bedside, using it on patients to demonstrate its efficacy and its effectiveness that can then be introduced into wide NHS practice. So that's where we see our real focus.
The knee pain was gradually getting worse. I was unable to do everyday things as the pain got worse. Hoovering, I had to hand over to my husband to his delight. Standing at the sink, just doing the simple tasks of washing up, etc. Going up and down stairs, especially going downstairs, was particularly difficult. And I used to sit and work out when someone suggested going somewhere, can I make it? Is it going to be painful? What are there any steps involved, etc., etc. And 9 times out of 10, you would say no, or I would say no, because it was in the too difficult tray.
Osteoarthritis is very prevalent. It's said that at any 1 year, about 1 million people are seeking their general practitioner advice for osteoarthritis of the knee. The symptoms of osteoarthritis of the knee are pain and stiffness, but particularly pain. Patients usually start with complaint of pain on activities such as walking or going up and down stairs, but as the disease progresses, they may even get rest pain and complain of night pain. But once we've exhausted all the conservative measures and patients complain of significant pain, we then discuss knee replacement with them. Patients' expectations on knee replacement have changed dramatically over the last few years. Knee replacements have always lagged behind hip replacements as far as outcomes are concerned until recently. And patients are now seeing their friends and family having very successful outcomes with a knee replacement, and they've been able to return to hobbies such as playing golf and tennis without any pain. And patients are now coming in asking us for a knee replacement so that they're able to be more pain-free and return to their previous hobbies.
I think patient expectations are much higher now. We have younger patients coming into the system getting knee replacements. So getting back to activities like managing the stairs, no problem, cycling, hill walking. It's really important to get good range of movement in their knee if they're going to be able to get back to these activities after they've had their surgery. So that's really why we need to see prostheses available that offer patients that ability after they've had their surgery.
Whilst total knee replacement is a very successful procedure, research has demonstrated that between 10 and 20% of patients are not completely satisfied, citing limited mobility as their key reason. These patients are reminded of their total knee replacement every day during their struggle and their daily activities, such as stair climbing, inclines and getting out of chairs. Armed with this knowledge, Debre Synthes reinforced its commitment to patient care by developing a brand new knee system aiming to improve the quality of life of patients and improve stability and motion. Hence, the Attune knee system is the result of more than 6 years of extensive research to address the unmet needs of patients, surgeons and providers.
Debre Synthes Joint Reconstruction took an extensive approach to the research and development of the Attune knee system. We worked not only with a large surgeon team, but also global thought leaders from academia and industry. And that work led to a number of scientific breakthroughs that have been presented at international congresses and peer-reviewed journals. The objective of the research process was to understand causes of patient dissatisfaction. Once we understood those causes, we were able to develop innovative solutions to address those unmet clinical needs. The research process showed us that with traditional designs, small changes in the implant geometry could lead to important changes in the way that a patient moved. That led to the key technologies of the Attune knee system. Attune's Gradius curve is a patented gradually reducing femoral radius that provides patient with optimum stability throughout their range of motion. Our kinematic research showed us that we needed to look differently at posterior stabilised knees and look at the way in which the spine and cam interact and also their interaction with the soft tissue. The soft cam technology is designed to work with the femoral geometry and also the patient's soft tissue to provide them with optimum stability through the range of motion. With traditional fixed bearing knee designs, it's necessary for there to be some compromise in the way in which the femur moves on top of the tibia in order to account for the difference in the size of those bones. Logic Lock removes the necessity for that compromise and allows us to design the optimal solutions for Gradius and soft cam that deliver patient stability and motion. The more common problems that patients have after knee replacements is anterior knee pain. Our research showed that if we accounted for patient variation and soft tissue interaction, we could reduce the risk of that anterior knee pain. And so glide right articulation is designed to do that, giving patients appropriate conformity and constraint through their range of motion.
The Attune product's first and foremost developed for the patient, but any medical device has to interact with a lot of people before it even gets to the patient. So we wanted to make sure we developed a product that met the needs of the surgeon, They met the needs of the scrub team and sterilisation team, and also met the needs of the provider, all with the goal of delivering care more efficiently. At the Pure Synthes joint reconstruction, we know that good design is about more than just making things look good. And so we partnered with the people who train the designers of some of the most ergonomic and functional consumer products. We partnered with the Helen Hamlin Centre of Design at the Royal College of Art in London. We listened to the needs of the people who use our products, but in addition to that, we also observed those same people using our products in a technique called ethnography. And through that technique, we were able to uncover needs and challenges that those people hadn't been able to articulate previously. Now, we know that there's pressure on hospitals to do things quicker and faster with less resource, and we wanted to try and use that new knowledge, those insights, to help to deliver that. The insights we gained through this research process helped us uncover unmet user needs, and it was those unmet user needs that we used to drive the development of the instrument system. This instrument system reduces the physical burden on the hospital staff by having a greatly reduced weight compared to our predicate instrument systems. The system is also designed to be clear, and through high contrast markings and features such as red touch points for the surgeon, we believe we have made these instruments more intuitive to use, so that now the surgeon can focus on doing the surgery rather than having to worry about how to work the instruments. We also set accuracy and robustness goals for the instruments and tested them heavily against those targets. The result is a unique set of instruments, the Intuition Instrument System. And this system, in combination with the Attune implant, allows the surgeon to balance the soft tissues and have precise control over the implant position for the best fit for each and every patient.
I've learnt about Attune from a number of sources. One of the advantages of being a knee specialist, you can keep up to date with the literature and latest innovations. I chose Attune for Mrs. Sterling because I was impressed by the theory behind the Attune prosthesis. Mrs. Sterling is a very active lady with high demand, and I was comfortable using this new prosthesis, and I thought this would benefit her. My experience of Attune was just what I expected. The instrumentation was very clear and straightforward to use. The functionality on the table was excellent, and her recovery was very quick and straightforward. I believe the Attune knee replacement is meeting the expectation of both the patient and the surgeon. From the surgical point of view, the instrumentation is simple to use. The cuts, I feel, are much more accurate, and the check x-rays shows the alignment is much better than I experienced with previous knee replacements. I also believe that the change in design of the femoral part of the component stops this mid-range instability, and this is when I tested on the table and also in patients in the clinic. From the patient's point of view, the early outcomes seem to be extremely good, and the patients seem to be satisfied with the Attune prosthesis.
My life now has turned a complete circle. I'm able to travel, which I love doing. I love playing with the grandchildren. I'm back golfing again. All the things that I thought perhaps I wouldn't be able to do anymore because of the pain and all the restrictions, I'm now able to do, and I've just found my life back again.
We put all the information about our association and activities on our website, www.boa.ac.uk. I know, because I personally have loaded that information up, that it's very comprehensive, and it sets out in great detail all our strategies, but helpfully it also links across to other sources of information, other useful sources of information for both surgeons and, importantly, for patients, on the procedures and techniques of surgery that they may be likely to receive.